Hi class, I'm Kalia,
And I'm Ellis.
and we're going to talk about obesity across the lifespan.
And the effect on cardiac, vascular, pulmonary, and endocrine disorders. So this is a video on obesity. Just watch it when you get a chance. So in the US, 1 in 3 adults are considered to have obesity, and 1 in 6 children and adolescents are considered to have it. 5% of the US population is considered morbidly obese, and there's a greater prevalence for people with disabilities. In the world, the obesity rate has doubled between 1980 and 2008, and the number is continuing to rise today. And 13% of the world is considered obese. So these are the classifications. So if you're underweight, your BMI is less than 18.5. Normal is between 18.5 and 24.9. You're considered overweight if your BMI is between 24.9 and 29.9. And obesity type 1 is 30 to 34.9. Obesity type 2 is 35 to 39.9, and morbidly obese or type 3 is your BMI is 40 or greater. So some characteristics of obesity. Your body fat raises your BMI to 30% or greater. You have joint pain or discomfort due to the increased weight. Overeating, low self-esteem, hypertension, and pot belly is shown here in this picture. And an increased body fat can lead to a variety of other health issues that we'll explore. Obesity affects the cardiovascular, musculoskeletal, respiratory, digestive, and endocrine system, and it has a negative effect on the entire body. So some of the risk factors for obesity: age, a family history, your genetics, your diet, high fatty burgers like this one, and physical activity or inactivity. Obesity is preventable. So there's quite a few interventions for obesity. The first one's pharmacological. Anti-obesity medications such as orlistat, phentermine, lorcaserin, naltrexone SR, and liraglutide are all used to reduce high glucose levels and control dyslipidemia. Medical interventions, there's occupational and physical therapy. Liposuction is a surgical one, just to take that fat right out. And lifestyle changes such as an improved diet and increased physical activity. So the settings include a home setting, acute care, hospital, and nursing homes. And the interprofessional team can include physicians, nurses, dietitians, pharmacists, psychiatrists, and psychologists, OTs, PTs, some self-care by the patient, and a surgeon if necessary. Some comorbidities of obesity include endocrine disorders such as diabetes mellitus, cardiac conditions such as MI, CID, arrhythmias, heart failure, congestive heart failure, and pulmonary conditions such as COPD, ARDS, pulmonary hypertension, and pneumonia.
So diabetes has two categories. Diabetes mellitus, which is a disease where glucose is insufficiently metabolized, and then you have diabetes insipidus, which is the other diabetes, and it's a rare condition caused by a deficiency of ADH, which increases the kidney's ability to reabsorb water and increase polyuria. Both of these affect the endocrine system. Below there is a video, so when you have the time, just take a look at it. So there are two types of diabetes mellitus. You have type 1 diabetes, which is juvenile. This cannot be prevented. It's insulin dependent, and it's where insulin is not produced or released into the bloodstream, and amino acids and lipids are not able to store the glucose. Some possible causes are linked to viral illness that trigger autoimmune response in those who are genetically predisposed, and it has lowered insulin resistance. The other type of diabetes mellitus is type 2 diabetes. This can change with lifestyle improvements. It's where the pancreas is unable to produce the insulin needed in the body. B cells produce insulin, but in insufficient amounts, and no glucose is available. It also comes with polygenic disorder, which is when the body begins to burn protein and fat. For diabetes insipidus, there's also two types. You have nephrogenic diabetes, which is when the kidneys are unable to respond to ADH, even though there's enough ADH in the system. And then you have central diabetes, which is where the ADH is lacking or produced in insufficient amounts. So for diabetes mellitus, the latest estimates show a global prevalence of 382 million people with diabetes in 2013. You have type 1 diabetes, which makes up for 5% to 10% of all diagnosed diabetes mellitus cases, and then you have type 2 diabetes, which accounts for 90% of all diabetic cases, typically in individuals over the age of 40. For diabetes insipidus, it's a rare disease. It's prevalent in 1 in every 25,000 people. It can present at any age, and the prevalence is equal among males and females. Less than 10% of DI is hereditary, X-linked, and then it accounts for 90% of cases in congenital NDI and occurs with a frequency of about 4 to every 8 in 1 million male live births. It's also autosomal. So signs and symptoms of diabetes all differ slightly between type 1 diabetes, type 2 diabetes, and then diabetes insipidus. So for type 1 diabetes, it's an abrupt onset around age 30. You show fatigue, weight loss, with overeating, irritability, emotional liability, orthostatic hypotension, arrhythmias, weakness, muscle cramps, delayed healing. You're prone to infection, polydipsia, polyuria, nausea, vomiting, and visual changes. And for type 2 diabetes, it's a gradual onset around age 30. And you show fatigue, weight gain, emotional liability, irritability again, hypertension, heart disease, stroke, paresthesia, sensory neuropathy, myopathy, dry skin, delayed healing, you're prone to infections, you have visual changes, and gastroparesis. For diabetes insipidus, you show fatigue, dehydration, sudden weight loss, lethargy, irritability, restlessness, confusion, tachycardia, hypotension, weakness, hyperflexia, spasticity, dry mouth, inability to sweat, decreased skin turgor, abrupt polydipsia, polyuria, and nocturia. So for type 1 diabetes, some risk factors are family history, environmental factors, presence of damaging immune system cells, and dietary factors. For type 2 diabetes, weight or obesity is definitely a risk factor, inactivity, family history, race, age, and gestational diabetes. For insipidus, brain injuries, strokes, kidney abnormalities, tumors, and lithium are definitely risk factors. So for diabetes mellitus, some comorbidities are chronic micro and macro vascular pathologies. This has to do with atherosclerosis, which is plaques of fatty material, retinopathy, which is vision impairment, nephropathy, which is kidney problems, and neuropathy, which is peripheral nerve dysfunction. Also, some comorbidities are prediabetes, hyperglycemia, and hypoglycemia. Prediabetes is when fasting blood glucose is higher than normal. Hyperglycemia is abnormally high blood sugar, and hypoglycemia is abnormally low blood sugar. For diabetes insipidus, it's just low blood pressure and shock as a comorbidity. So as far as settings and interprofessional team, some settings are home setting, acute care setting, a hospital setting, and nursing homes. And for our interprofessional team, you have physicians, nurses, dietitians, pharmacists, psychiatrists, psychologists, physical therapists, occupational therapists, and especially for diabetes, self-care. So for interventions, type 1 diabetes, you have lifelong insulin therapy either through injection, subcutaneously, inhalation, or through infusion. Two types are rapid acting and short acting, and then intermediate and long acting. And then as well as this, you have self-monitoring of the insulin levels. For type 2 diabetes, an intervention can be aerobic and resistance training. You also have hypoglycemic medication known as metformin. This slows production and release of glucose from the liver and enhances insulin sensitivity. If the target is not achieved after 3 months, additional medication will be administered. For diabetes insipidus, you have vasopressin, which controls polydipsia, polyuria, and dehydration. And then as well as that, you have diuretics, ADH-releasing medication, and anti-inflammatory medication for nephrogenic diabetes insipidus.
So now we're going to talk about cardiac disorders. The first one's myocardial infarction. So it affects 32.4 million people worldwide, and of those 32.4 million, 17.5 do die. It affects 790,000 people in the United States, and it's more common in men over the age of 40. So some risk factors for MI: family history, high cholesterol, smoking, diabetes, stress, physical inactivity, obesity, and hypertension. So some characteristics of MI: there's an unstable angina which leads to reduced blood flow and oxygen to the heart. The endocardium is the most susceptible to damage. Tissue damage, necrosis, and coronary artery rupture are also characteristics. It's also known as a heart attack, and some of the symptoms are chest pain, nausea, vomiting, shortness of breath, fatigue, anxiety, restlessness, and in women there's a burning chest pain and pain in the abdomen or back. The systems affected for MI are the cardiovascular, muscular, and respiratory system, and some comorbidities are arrhythmias, cardiogenic shock, pericarditis, clots, congenital heart failure, and sudden death. So a pharmacological intervention is antiplatelet agents such as aspirin, which help prevent platelets from sticking together and creating more clots. Beta blockers help lower blood pressure, prevent future heart attacks from happening. Nitroglycerins also used. For medical interventions, there's occupational therapy, cardiac rehab to strengthen the heart muscles, and supplemental oxygen therapy, which makes sure the patient's receiving suitable amounts of oxygen. Surgically, there's revascularization surgery, and that's when bypass grafts are inserted to bypass the blockage of plaque. So some settings include the home setting, acute care, hospital, and nursing homes. The interprofessional team is composed of physicians, nurses, pharmacists, psychiatrists, psychologists, OTs, PTs, and a surgeon if necessary. So the next topic we're going to cover is coronary artery disease. The epidemiology: it's the most common heart disease in the U.S. It accounts for 1 in 4 deaths, or 405,000 people, and the prevalence for adults age 60 plus. In men, it's 19.9 to 32.2%, and women is 9.7 to 18.8%. Risk factors for CAD include family history, high cholesterol, smoking, diabetes, stress, physical inactivity, obesity, and hypertension. So it develops really without many symptoms present. Some include shortness of breath, angina, nausea, diaphoresis, and atherosclerosis, which is the gradual narrowing of the vessel, and it allows less blood to pass through. So it affects the cardiovascular system, and some comorbidities are angina, arrhythmias, heart failure, myocardial infarction, ischemic heart disease, and sudden death. So some pharmacological interventions are beta blockers, calcium channel blockers, and statins. Medical intervention: there's risk factor modification, lifestyle changes, cardiac rehab, OTPT, and surgically there's coronary artery bypass graft, atherectomy, and percutaneous coronary intervention, which is a balloon angioplasty with a stent replacement. So some settings include home setting, acute care, hospital, nursing homes. Interprofessional team: there's physicians, nurses, pharmacists, dietitians, psychiatrists, psychologists, OTPTs, and surgeons. Arrhythmias affect 2.3 million people in the U.S., and it occurs in 6% of people over 65 and 12% of people that are over the age of 85. Risk factors for arrhythmias include CID, high cholesterol, smoking, diabetes, stress, overconsumption of alcohol, obesity, and hypertension. There's many different characteristics and types of arrhythmias. So an arrhythmia is an irregular or abnormal heart rhythm. Bradycardia is if your heart rate is less than 60 beats per minute. Tachycardia is if it's greater than 100 beats per minute. Fibrillation is a rapid irregular contraction of the atria or ventricles, and there's atrial flutter as well. And some symptoms include fatigue, dizziness, syncope, pre-syncope, palpitations, shortness of breath, chest pain, and fever. Arrhythmias affect the cardiovascular system, and some comorbidities are heart failure, MI, heart disease, hypoxia, hypertension, CHD, hyperthyroidism, and a TBI. Antiarrhythmic drugs are used to treat arrhythmias. Medically, there's cardioversion, which is an electrical shock to the SA node to get it back on rhythm. There's atrial pacing and closely monitored therapy with an OT and a PT. Surgically, you can have a pacemaker implanted, or you can have a cardioverter defibrillator implanted, which does the cardioversion, that electrical shock to the SA node. Treatment of arrhythmias can take place in acute care, hospital, and nursing homes. And the interprofessional team, there's physicians, nurses, pharmacists, OTPTs, and the surgeon if you need it. Heart failure and congestive heart failure are next. And heart failure is when there's a weakened heart and it's unable to meet the metabolic needs of the body. There's an abnormal ejection factor. The chambers are enlarged, which reduces the output, and it causes the backup of blood into the venous system, and it leads to edema in the visceral, pulmonary, and peripheral tissues. Congestive heart failure, there's also the weakened heart and the abnormal ejection factor, but this leads to a buildup of fluid in the lungs and the surrounding tissues. There's two different types of heart failure. There's compensated and decompensated. Compensated is when the patient's medically stable, they're able to maintain circulation and do not need supportive devices to live life. Decompensated is when the patient's not stable, they are unable to maintain that adequate circulation, so there's not enough oxygen getting throughout the body. They need treatment to sustain life, whether that's breathing assistance, and the compensatory mechanisms become ineffective. And some of these mechanisms include the enlargement of the ventricles, the sympathetic nervous system activation, which increases your heart rate and the amount of oxygen throughout the body, and the activation of the renin, angiotensin, and aldosterone system, and that increases sodium and fluid retention because there's a lack of blood flow to the kidneys. Heart failure affects 20 out of every 1,000 people between the ages of 65 and 69. It affects 80 out of every 1,000 people aged 85 and above, and the prevalence is increasing because the aging population is growing, and 5 million Americans have congestive heart failure. Symptoms for heart failure include dyspnea, fatigue, and edema, and for congestive heart failure, the shortness of breath, dyspnea, orthopnea, fatigue, exercise intolerance, a dry hacking cough, hepatomegaly, weight gain, and edema of the lower extremity. Risk factors include hypertension, a pre-existing heart disease, MI, medications, stress, obesity, thyroid disorder, diabetes, infection, and alcoholism. And classifications, there's the right-sided heart failure and the left-sided heart failure, which is more common. Systolic, which is when the ventricles enlarge. There's hypertrophy, and there's a problem with the systole and ventricular muscle contraction. And diastolic, there's the ventricle relaxation phase that's impaired. The cardiovascular and respiratory systems are affected by this, and comorbidities include hypertension, MI, valvular disease, cardiomyopathy, inflammatory diseases such as endocarditis, pericarditis, and myocarditis, CID, pulmonary disease, and renal disease. Heart failure medications are typically used to decrease stress put on the heart and the blood flow. Medically, you can use closely monitored therapy, revascularization, pacemaker insertion, heart valve repair, angioplasty, ventricular assistive devices, or heart transplants are all done surgically. And you can change your lifestyle, such as diet, and increase your physical activity. Settings include long-term care, hospital, and acute care settings, and the interprofessional team has physicians, nurses, pharmacists, dietitians, psychiatrists, psychologists, OTs, PTs, and the surgeon. Angina is the next cardiac disorder, and it affects 8 million Americans. And for men older than 60, it affects 8.9 to 10.3%, and women 5 to 11%. Angina is a pain in the chest, but it can also feel like pressure, tightness, or squeezing, and occasionally you can feel it in your left arm, your neck, or your jaw. There's 3 different types of angina. There's stable, unstable, and Prinzmetal. Stable is the most common, and you get it from doing physical activity, and the best way to resolve it is just rest or take some medication such as nitroglycerin. Unstable, there's no pattern. It can occur when you're resting, when you're doing an activity. There's no telling when it will strike, and there's a rupture of plaque that blocks your coronary arteries, and sometimes this requires emergency treatment since it can be an indication of a heart attack. Prinzmetal is a rare type of angina, and it's caused by an occultation of blood by vasospasm and not atherosclerosis. And it can be triggered by exposure to colder weather, smoking, cocaine use, and emotional stress. Angina affects the cardiovascular system, and some comorbidities are hypertension, myocardial infarction, valvular disease, cardiomyopathy, CAD, pulmonary disease, and arrhythmias. Nitroglycerin is a medication taken to treat angina, and medically you can have closely monitored therapy. Treatment of angina can occur in acute care, nursing homes, long-term care, hospitals, and home settings. And the interprofessional team, there's the physician, nurses, pharmacist, OTs, PTs, psychiatrists, psychologists, and the patient themselves. Cardiomyopathy affects 5 in every 100,000 adults in the U.S. and is the third leading cause of heart failure. And with cardiomyopathy, the heart muscle thickens, enlarges, or stiffens to a point where it's unable to maintain normal electrical rhythm. There's 3 different types of cardiomyopathy. The first is primary, and 3 types of primary cardiomyopathy include hypertrophic, dilated, and restrictive. Hypertrophic is when the left ventricle and interventricular septum thicken, which leads to the left ventricle not being able to fill as much during systole. This increases the pulmonary pressure and dyspnea. It's hereditary, and it's the most common form of death in young athletes. Dilated cardiomyopathy is when the heart muscle loses its tone, so the heart chambers become dilated or enlarged. Again, the left ventricle is going to lose its contractibility and isn't able to take in as much during systole, so the cardiac output is going to decrease, and you're at a greater risk for clots. Restrictive is the least common form. There's thickening and rigidity of the myocardium, and this is irreversible, and prognosis generally is very poor. The 2 other types of myocardiopathy are acquired and secondary. With acquired, it's an inflammatory type, which also has myocarditis, and this can be caused by an immune response, viruses, bacteria, fungi, protozoa, and other factors. Secondary is a systemic disease with myocardial involvement, although it's not particularly contained to the heart, so it goes along with other diseases such as infiltrative, storage, inflammatory, and endocrine disorders. Some risk factors, signs, and symptoms include myocardial contractibility, genetic shortness of breath, cardiomegaly, palpitations, fatigue, and weakness. And some comorbidities include arrhythmias, angina, hypertension, ischemic disease, thyroid disease, valvular disease, and diabetes, and the cardiovascular system is affected. For interventions, there's anticoagulants, antiarrhythmic drugs, vasodilators, and diuretics that can be used for the pharmacological intervention. Medically, you can use therapy, preferably closely monitored. Surgically, there's the LVAD placement, a pacemaker implant or heart transplant, and you can have lifestyle changes where you have a lower sodium diet and you manage your weight. So some settings include acute care, nursing home, long-term care, hospital, and home setting. And the interprofessional team, there's physicians, nurses, pharmacists, dietitians, OTs, PTs, psychiatrists, psychologists, and surgeons if necessary.
For the systems affected, COPD, emphysema, pulmonary hypertension, ARDS, and pneumonia all affect the respiratory system, pulmonary system, cardiovascular system, and the central nervous system. COPD is known as chronic obstructive pulmonary disease. It is preventative yet progressive. It's a lung disease defined by chronic airflow limitation. It is inflammatory. It has a loss of elastic recoil and restricted airway. It has reduced expiratory airflow and decreased pulmonary function. You cannot have COPD without having emphysema. So emphysema, on the other hand, is a common type of COPD that destroys the alveoli walls, causing large air sacs. It's recurrent inflammation. It causes trapping of the air, has loss of elastic recoil, hyperinflation, decreased O2, and you can have this condition without having COPD. For the epidemiology, chronic obstructive pulmonary disease shows a 6.4% diagnosis yearly in Americans, and then 65 million people have COPD across the world. So emphysema, 46 million Americans are diagnosed yearly. Incidence has risen in women while declining in men, and 90% of all cases involve women over the age of 45. For symptoms of COPD, it's seen at a middle age onset. It has long history of tobacco use, a chronic cough, exposure to dust or chemical history, indoor air pollution, and some others as seen. Research does show that fatigue and dyspnea are the most debilitating symptoms affecting the general health for COPD patients. As far as emphysema, dyspnea on exertion in progress, malnutrition, anorexia, muscle wasting, fatigue, clubbing of digits, decreased chest expansion, rapid shallow breathing with use of accessory muscles, smoking, antitrypsin deficiency, cognitive and psychological sequel, and mild hypoxemia are symptoms as well. As well as this, you have severe hypoxemia. For mild hypoxemia, it's impairments in abstract thinking, verbal and nonverbal learning, and for severe hypoxemia, it's impairments in abstract reasoning, attention, memory, and auditory stimuli. So COPD is an umbrella term that describes a group of breathing conditions. Under COPD, you have emphysema, asthma, and chronic bronchitis. Asthma is just a bronchial constriction of the airway and hyperresponsiveness, and chronic bronchitis is chronic productive cough that lasts for more than 3 months, and emphysema will be discussed in further slides. So for classification of emphysema specifically, it has to do with antitrypsin deficiencies. Antitrypsin deficiency is a genetic form of emphysema that results from a deficiency of the antitrypsin protein. This is a protein that is produced in the liver and inhibits the release of neutrophil elastase. Causes of this are destruction of the lung tissue that leads to liver disease. It can occur before age 45, and 5% of the cases are identified in COPD overall. As far as treatment, cessation of smoking, bronchodilators, steroids, and supplemental oxygen are definitely recommended. Some risk factors for COPD involve age, gender, history of tobacco use, environmental exposure to toxins, allergens, genetics, and obesity. Some risk factors of emphysema are smoking, antitrypsin deficiency, and obesity. So as far as comorbidities, it's kind of the same for both COPD and emphysema. So depression, this is most strongly linked to the decrease in exercise capacity and shortness of breath. Respiratory failure, dyspnea in the elderly, heart failure, pulmonary embolism, anxiety, cardiac disease, diabetes mellitus, hypertension, osteoporosis, cardiovascular and cerebrovascular disease, and cancer. As far as interventions for both disorders, cessation of smoking is definitely the most important treatment. Pharmacological, there's no cure, but it focuses on management of symptoms and slowing the disease progression. As far as medications, inhaled bronchodilators, beta agonists, oral corticosteroids, antibiotics, mucolytic agents, oxygen therapy. And then for non-surgical, you have ventilators. For surgical, you have a bolectomy, a lung transplant, and a lung volume reduction surgery. And then for non-medical, it can be dyspnea control postures, pursed lip breathing, PLB, diaphragmatic breathing, and dietary changes. So for settings for both disorders, you have home setting, an acute care setting, a hospital setting, and nursing homes. For an interprofessional team, it involves physicians, nurses, pharmacists, psychiatrists, psychologists, a surgeon, a physical therapist, and then an occupational therapist, which assists patients by modifying and grading activities, facilitating engagement in ADLs, modifying their environments, evaluating their adaptive equipment needs, educating the patients on energy conservation, and OTs also provide psychological support when needed. Next is pulmonary hypertension. For pulmonary hypertension, it's a pulmonary vasculature, which is an obstruction of pulmonary blood vessels. It's known as the other high blood pressure, and it's rare but progressive and is characterized by elevated pulmonary artery pressure, often associated with heart, vascular, or lung parenchymal disease. This results from increased pulmonary vascular resistance from hypoxic vasoconstriction and remodeling of destruction of pulmonary blood vessels. The way this disorder is diagnosed is seen below. Women are at a 60% greater risk than men in contracting this disease. It affects young and otherwise healthy individuals. The average age of diagnosis is 36 years of age. About 15,000 deaths per year this causes. Most medical references to heart failure are for left heart failure, which in the United States has a prevalence of about 4.9 million and an annual incidence of 378 per 100,000 deaths. Pulmonary hypertension, which causes right heart failure, affects all races and socioeconomic levels. As far as symptoms, they usually start off asymptomatic or have very vague or mild signs. Others are dyspnea on exertion, chest pain, shortness of breath, a cough, fatigue, dizziness, syncope, progressive exercise intolerance, ascites, heart murmur, hemoptysis, palpitations, and cyanosis. Some risk factors involve family history, obesity and obstructive sleep apnea, gender, pregnancy, altitude, drugs and toxins, and then other diseases. So for pregnancy, women who already have pulmonary hypertension and become pregnant, they have a much higher risk of mortality. And as far as other diseases, these include congenital heart disease, lung disease, liver disease, and connective tissue disorders like scleroderma, and lupus. These can lead to the development of pulmonary hypertension. As far as classifications, pulmonary hypertension has groups. There used to be two groups, including primary, which was the known cause, and secondary, which was the unidentifiable cause, but it's now split into 5 groups. So group 1 essentially is just pulmonary arterial hypertension, and then groups 2 through 5 consist of collective forms of pulmonary hypertension. So for group 2, it consists of pulmonary venous hypertension with left heart disease. Group 3 is pulmonary hypertension associated with lung disease, hypoxemia, or both. Group 4 is pulmonary hypertension including or resulting from chronic thromboembolic disease, embolic disease, or both. And then group 5 is a miscellaneous cause. So some characteristics are the right side of the heart has to work a little harder to pump the blood to the lungs, and this can cause a cor pulmonale, which is a condition in which the right ventricle hypertrophies and weakens. Some comorbidities of pulmonary hypertension are heart failure, coronary artery disease, myocardial infarction, stroke, congestive heart failure, and peripheral vascular disease. For pharmacological intervention, you have epoprostenol, which is effective in slowing down pH. As far as medications, you have supplemental oxygen, diuretics, and vasodilators. And then for surgical interventions, you have an arterial septostomy, a lung transplant, or a heart-lung transplant. And then for non-medical, patients can also benefit from education on energy conservation and pulmonary rehabilitation. For settings, you could see this in a home setting, acute care setting, hospital setting, or nursing homes. And for the interprofessional team, you have physicians, nurses, pharmacists, psychiatrists, psychologists, occupational therapists, physical therapists, and surgeons. So next we have adult respiratory distress syndrome, also known as ARDS. This is also known as an acute lung injury. It's a syndrome that develops from systematic pulmonary disorders. It's not a disease, but it has fluid buildup in the alveoli that impairs gas exchange. So fewer than 200,000 U.S. cases are seen per year in ARDS. Among ICUs in 50 countries, there was a 10.4% ARDS case in ICU admissions. ARDS can occur in those who are critically ill or have trauma to the lungs. Some conditions and characteristics involve dyspnea, tachypnea, and hypoxemia. These are all resistant to oxygen therapy. Some risk factors include increase in age, drug toxicity, inhalation injury, sepsis, shock, infection, pulmonary trauma, lung contusions, near drowning, multiple blood product transfusions, and aspiration of gastric contents. Some possible comorbidities for ARDS is multiple organ failure, blue skin from poor circulation, coughing, high carbon dioxide levels in the blood, muscle weakness, organ dysfunction, possible fatality, and respiratory failure. So treatment focuses on addressing the underlying cause of ARDS due to its high risk for its comorbidities. Pharmacological interventions include tracheal intubation, mechanical ventilation, continuous positive airway pressure, known as CPAP, and oxygen therapy. Some medications are vasoconstrictors, phenylephrine, norepinephrine, and epoprenol. Surgical interventions are in atrial septostomy, lung transplant, or heart-lung transplant. Non-surgical, an induced coma. And then non-medical is education on energy conservation and pulmonary rehabilitation. For settings, these can be seen in intensive care units, nursing homes, and even in home care. For the interprofessional team, you have physicians, nurses, pharmacists, psychiatrists, psychologists, occupational therapists, physical therapists, and surgeons. So next we have pneumonia. It is an inflammation of lung tissue caused by acute injury. It is an agent causing inflammation that is either inhaled or aspirated directly into the lungs, or it is already present in the mouth. It can result in direct lung infection from a different respiratory systemic condition. It's categorized by agents known as bacteria, virus, or fungi, inhaled substances, or location of lobes or bronchioles. And basically, its comorbidities lead to death. So pneumonia kills 52,000 people per year in the US. It is the leading cause of death, and it targets the older population with other respiratory diseases. So pneumonia is split into three groups. You have community-acquired pneumonia, aspiration pneumonia, and hospital-acquired pneumonia. So these are separated by comparison. So for community-acquired pneumonia, it's rare in healthy people, is developed when the patient is still living in the community. It accounts for 1.7 million inpatient hospitalizations per year. It manifests before hospitalization or within the first 72 hours. And causes of CAP can be bacteria, influenza, viral or fungal infections, and for prevention, vaccines are the best approach. As far as aspiration pneumonia, this is the leading cause of hospital-acquired pneumonia and ventilation-acquired pneumonia. This can occur from inhalation of food, liquids, or gastric contents, or aspiration of colonized secretions or bacteria. Aspiration pneumonia causes lung inflammation and may be difficult to detect. Its risk factors can be poor oral hygiene, and it also has predisposing conditions, as listed. For hospital-acquired pneumonia, it occurs 48 hours after admission, has a mortality rate of up to 60%, is the leading cause of death from nosocomial infections. Multi-drug resistant organisms may be an important consideration when having hospital-acquired pneumonia. Ventilator-acquired pneumonia, VAP, occurs within 48 hours of intubation and mechanical ventilatory support. And then VAP can occur because placement of an endotracheal tube or tracheostomy or tracheostomy bypasses the body's normal defenses versus respiratory infection. As far as signs and symptoms, for pneumonia, you'll usually see a cough, malaise, dyspnea, tachypnea, fever, headache, or the chills. So some risk factors include age. So adults at the age of 65 years and up are at a high risk, and then very young children. Risk factors include history of smoking, compromised immune system, history of chronic lung disease, antibiotic use within the last 3 months, patient hospitalization for over 5 days, use of mechanical ventilation, loss of consciousness, aspiration of food or liquids, especially those with traumatic brain injuries or brovascular accident whose swallowing is affected. And then other risk factors are therapies that elevate pulmonary hypertension, presence of nasogastric tubing, and those who have undergone chest or abdominal surgery. As far as interventions, overall treatment includes prevention, rest, antibiotics, oxygen therapy, fluids, and in some cases, mechanical ventilation. So as far as settings, this is seen in acute care, hospital care, and nursing homes. And for the interprofessional team, you have physicians, nurses, pharmacists, physical therapists, and lastly, occupational therapists.